Okay, it's 11 o'clock. Let's get started. Thank you from the Institute for Diversity Sciences for joining us today. I'm Marcus Brouwer. I'm the Executive Director of the Institute for Diversity Science. It's a research institute at the University of Wisconsin. And the mission of that institute is to promote data-driven empirical research on questions related to diversity, equity, and inclusion. Today, we're going to be talking about the intersection of disability and aging. And I don't know about you, for many years, when I imagined the prototypical person with disability, I sort of imagined a young person. Well, people with disabilities age, and then you have the intersection of elderly individuals and people with disabilities. And the whole thing is becoming even more complex when you then add in economic inequality, differential access to resources and benefits, racial and ethnic inequalities. All of this becomes a very complicated question. We have the fortunate situation to have three highly qualified experts with us who will tell us about what they've done in this domain. Let me briefly introduce them. One is Lauren Bishop, who is Associate Professor of Social Work here at the University of Wisconsin-Madison. She's also affiliate of the Institute for Diversity Science. Then we have Judy Goldberg Dey. She's an economist, and she works at the Office of Behavioral Health, Disability, and Aging Policy. And finally, we have Gina Green-Harris, who's the director of the Center for Community Engagement and Health and Partnerships. She has plenty of other responsibilities here at the School of Medicine and Public Health at the Milwaukee Regional Office for the Wisconsin Alzheimer's Institute. Let me tell you what's going to happen here in the next 55 minutes. In just a moment here, I will give each of the speakers the opportunity to briefly introduce themselves. After that, I will ask each of our panel members to give short presentations, around 8 minutes, where they tell us about the work that they have done in this domain. Then there will be a number of follow-up questions for our guest speakers here on the panel and a brief discussion. And then we're going to open it up for webinar attendees to ask questions. And again, we will have a discussion. The goal is to end exactly at noon, and I will start wrapping it up shortly before the hour. I want to mention that we do have captions enabled today, if those are helpful for you. We're also recording this seminar, and we will send a copy of the recording to registered attendees in a few days. Okay, let's get started. I'm looking forward to our guest speaker. May I ask you to briefly introduce yourself, and let's start out with Lauren.
Hi there, I'm Lauren Bishop. I'm an associate professor in the Sandra Rosenbaum School of Social Work, and I run my lab out of the Waisman Center at the University of Wisconsin-Madison. Broadly speaking, my research program focuses on helping adults with intellectual and developmental disabilities to live long, healthy, and self-determined lives in their community. And I study disparities in health and well-being and mechanisms underlying both healthy aging and early and accelerated aging in autistic adults as they age. Thank you.
Thank you, Lauren. Judy, do you want to go next?
Sure thing. Hi, everyone. My name is Judy Dey, and I work in the U.S. Department of Health and Human Services. I work in the Office of the Assistant Secretary for Planning and Evaluation. And as Marcus already mentioned, within there, I work in the Office of Behavioral Health, Disability, and Aging Policy. We are a principal advisor to the U.S. Department of Health and Human Services Secretary, which is kind of exciting. And our portfolio includes thinking about the ways in which changes to the population will impact the use of Medicaid. That's one of many things, but I think that's the one that's relevant for this presentation. Medicaid is one of the primary payers of long-term services and supports, both institutional, like in nursing homes, and home and community-based services. Long-term services and supports help people with physical and cognitive disabilities meet their needs. And this includes things like personal care assistance with activities of daily living, like bathing, dressing, and eating. We know that eligibility for Medicaid is based on need as well as income levels, but we also know that unpaid caregivers at home provide the majority of help that people need. And without it, more people would need to use Medicaid. The research project that I'm going to present on came about because there's just a lot of attention in the media about this tsunami of aging, like that we're going to have so many baby boomers aging, and that they weren't going to have caregivers because they were less likely to be married or have children compared to people that came before them, and that this was going to be a problem for the Medicaid program. And I just sort of immediately bristled with that, because I know that plenty of people find other solutions for caregiving, and that our families don't all look alike. So I wanted to look at this and really look into, how do people right now get the care they need? How do people without spouses and children lean into their networks right now for caregiving? And what does this mean about our future? The work that I'm presenting goes along with other work that explores the availability of caregiving and the risk of economic hardship by race and ethnicity and income. Sorry, I was probably a little long, but I'll turn it back to you, Marcus.
You do fascinating work, Judy. Gina, you're next. Tell us about the many, many, many things that you do in your busy life.
Yes, good morning, everyone. Gina Green-Harris. I am Director of the Center for Community Engagement and Health Partnerships at the UW-Madison School of Medicine and Public Health. I also do serve as the Director of the Wisconsin Alzheimer's Institute Regional Milwaukee office. And then I do some other work with portfolio projects as well through the Dean's office. And so my work and my research is really focused on asset-based community development models, along with community-based research and community-based participatory research. Specifically, what I enjoy doing and what we're going to talk about today is, how do we build through research using cultural lenses, connecting investigators to research with our communities that are maybe aging, disabled, having challenges, but also the point is to work with community to build those programs. And so my passion is really talking about, how do we work within our current infrastructure to rethink how we develop innovative programs that optimizes the strengths of the community versus the deficits of the community. And so we'll talk a little bit about that. And then what we also want to remember is that using this asset-based model means that we recognize community as community scientists and what they can do to contribute to keeping themselves, as we help them with these programs, stay home safer and longer. With that, I'll turn it back over to you, Marcus.
Thank you, Gina. One of the fun parts of my job as executive director of the Institute for Diversity Science is that I get to interact with these incredibly intelligent people who do fascinating work, and I'm very excited about what we're going to hear next. I especially appreciated the fact that you mentioned the important role that research plays in the work that you're doing. I'm going to hand it over to Lauren. Lauren, you have about 7-9 minutes to tell us what you do. I think you have a PowerPoint presentation, and we're eager to hear what you have to say.
Yeah, so thank you so much, Marcus. So today I'm going to talk about aging among autistic people. And I first want to start off by giving a disclaimer about the way that I'm using language here. So I'll be using what I call identity first language throughout my presentation. And what that essentially means is that I'm saying autistic people rather than people with autism, which would be person first language. I use identity first language because this is the preferred language among the stakeholders who I work with. But there are many different preferences within the community about whether folks prefer identity first language or person first language. So I first want to talk a little bit about autism and what autism is. So autism spectrum disorder is characterized by two different diagnostic components. So first, challenges with social communication, and then the presence of what we call restricted interests and or repetitive behaviors. And this can look really different from person to person. There's a lot of heterogeneity, and autism can present very differently among different people. Importantly to think about, autism currently infects about 3% of the population of US children. We know at this point that there are about 5.5 million autistic adults in the US, and that number is just growing over time. We also, can think about autism and aging within the context of changes in diagnostic practices. So the way that we diagnose autism, the way that we think about autism, this has changed greatly over time. And this leads to cohort effects wherein the folks who were diagnosed in childhood in the 90s or early 2000s may look different from folks who were diagnosed in adulthood as diagnostic criteria have changed. I think really importantly to this discussion, autism is a lifelong condition. However, only about 0.5% of the funded research by the NIH has been focused on aging specifically, even though autistic people live relatively similar lives in terms of life expectancy to non-autistic people. We also need to think about this diagnostic boom that we've seen. So the folks who were diagnosed at the beginning of the diagnostic boom in 2000 are now going to be in their early 30s. And we'll just see the proportion of autistic people within our service systems increase over time as we see this diagnostic boom hit midlife and old age in autistic people. So autism is, in the grand scheme of things, a relatively new diagnosis. The first person who was ever diagnosed with autism died last summer at the age of 89. And this gentleman, Donald Triplett, was Connor, who was the first person to write officially about autism in the scientific literature, his first case that he detailed in his first report. And at this point, we have more adults who are identified with an autism diagnosis than ever before. However, there are many missed diagnoses or misdiagnoses. And, this can look like, for a missed or misdiagnosis, it can look like, the person who has a lot of success in their career and maybe works in academia or in computer programming, but has a really hard time with social life and with things like executive functioning. Or it could be somebody who was diagnosed with an intellectual disability, but their autism diagnosis was missed early on because of the way that we've changed how we diagnose autism. We do have a lot of research, including some research that we've done in my lab, that suggests that there may be early mortality in autism. We think that number is in the 3 to 5 year range in decrease in life expectancy, though we don't have any definitive life expectancy studies at this point. And we also see across research that we have greatly increased morbidity in autistic people over time, such that they experience more health problems at perhaps earlier ages than folks in the general population. However, we at this point have very insufficient research on health and health disparities, which limits our ability to make changes at the population or policy level or develop effective interventions. We also have to think about aging with intellectual and developmental disabilities within the social context. So deinstitutionalization happens in the very recent history of our country. In Madison, for example, there's still one longstanding asylum that houses folks with intellectual disabilities who've never lived in the community. Most people with intellectual and developmental disabilities, including autistic people, have experienced pervasive ableism throughout their lives that leads to a sequela of effects in the long term. And then in the US, we find that most people with intellectual and developmental disabilities access their healthcare through Medicaid and or Medicare, depending on the type of disability benefits they receive, either through supplemental security income or Social Security disability insurance. And overall, in the 60s, 70s, 80s, people with intellectual and developmental disabilities had greatly reduced life expectancies due to complications relative to their conditions, but we've seen these life expectancies increase to a relatively normal lifespan due to advances in medical care. So we also need to think about intellectual and developmental disabilities and autistic people specifically as experiencing many disparities related to their autism diagnosis. So we have very high rates of underemployment and unemployment. As much as 30% of autistic people are unemployed, and an even larger proportion are underemployed. We're studying this now, the experiences of poverty in autistic people, but we have some preliminary evidence that we have very high rates of poverty among autistic people. And if not poverty, we do see some level of food insecurity and some level of housing insecurity among a lot of autistic people. As I mentioned previously, there's a strong lived experience of ableism. And we have done research on service deserts and service oases, and we find that there are service deserts for autistic children that likely perpetuate into adulthood, both in urban areas and in rural areas. We also know that autistic people experience a lot of social isolation and social exclusion and very low levels of social support, which has, I think, pretty wide-ranging effects on health and well-being in folks as they age. And then, as I mentioned previously, we see increased morbidity and potentially slightly early mortality. There are a lot of really significant gaps in autism aging research. So at this point, we have a complete lack of population-level non-claims data, and most of our samples that are non-population level data will sometimes completely lack racial and ethnic diversity. We have not also done a full characterization of health and well-being in mid to late life, as well as looked at trajectories of aging outcomes in autistic people. These two things are things that we're addressing right now with some of our studies. And then we don't have good information on how social context and social determinants of health impact aging outcomes, in particular for autistic people who experience discrimination because of minoritized identities beyond being autistic. And then finally, we have not in the literature done a full characterization of cognition or cognitive functioning in later life among autistic people. So don't know a lot about dementia and whether we're seeing true dementia or autism-related cognitive decline. We have two studies that I'll touch on briefly. So we have a longitudinal study that we are working on at the Waisman Center, which is a large group study where we're establishing and following a cohort of 325 autistic and 225 non-autistic adults to look at longitudinal changes in aging-related decline across a number of different clinical health and brain imaging measures in autistic adults. And then we are collecting whole blood specimens that we are banking for future genetic studies to look at epigenetic and genetic influences. This is an Autism Center of Excellence grant, and it's the first one ever funded on aging. And then finally, we have a R01 right now through the National Institute of Aging, where we're developing an autism-specific mortality risk index using national Medicare data. And with this with this autism-specific mortality risk index, we're essentially attempting to use a new machine learning technique to develop an index that works better than the standard mortality risk indices that have been developed for the general population. And then I also want to just briefly touch on why aging and health disparities researchers who don't study autism should care about autism. So first of all, this is a massively understudied population with very high support needs who experience what we're thinking are pretty significant health disparities. Yet we don't have a lot of research in this area, which has really negative consequences for folks' ability to plan for the future and understand what their life might look like as they get older. We also, should think about for the general population how neurodiversity, or the concept of us all having different ways that our brain works, like autistic people do. This may impact cognition and motor outcomes and trajectories in people in the general population. And we can think about neurodiversity as a continuous variable, not a categorical variable, which tells us something about how individuals may be affected by their neurodiversity, regardless of whether they qualify for an autism diagnosis. And then finally, this may provide opportunities to better understand the impact of social disparities and social isolation on aging outcomes for people in the general population. So thank you so much, and I'll pass this over to the next presenter.
Wonderful. Thank you, Lauren. That was incredibly interesting. Without any further delays, I'm handing it over to Judy. Judy.
All right, let me just share my screen. Okay, so I am going to present our work on how the availability of informal caregivers, the amount of paid and unpaid care received and unmet needs vary by race and ethnicity. So I sometimes
Judy,
people.
I'm sorry, did you intend to share your screen?
Oh, I'm
Because
sorry. Am I not sharing my screen?
No.
Okay.
Now,
Okay.
perfect.
Well, you missed my first slide, but that's okay because it was just the title of my presentation. Sorry about that. So I sometimes people don't appreciate that, like, as we age, actually most of us will need long-term services and supports. And by that, and in this presentation, I'm really talking about kind of like, you need help bathing, dressing, eating, or you have, cognitive decline to the extent where you might need supervision most of the time. But our risk of needing care and having disability really just varies by our income, by our race and ethnicity, and by our family circumstances. So for this, oh, sorry, go back. I just want to touch a little bit on methods here. So for this work, we're using data that comes from the Health and Retirement Study, and also from a big microsimulation model that comes from the Urban Institute. And these allow us to explore relationships between race and ethnicity, family composition, caregiving, and future outcomes. Our estimates by race and ethnicity focus on 4 groups, and these are in the Health and Retirement Study: non-Hispanic white people, non-Hispanic Black people, Hispanic people, and non-Hispanic people of other races, where we've bundled a bunch of different groups that obviously have very important differences that we couldn't break apart with the Health and Retirement Study. And so those include things like Asian Americans, Pacific Islanders, Native Americans, and others. So I am now going to talk about the prevalence of disability. So we find that compared to white adults, people of color will spend more of their life with disabilities and not live as long. There's a lot of reasons for these. I don't think, there's like one reason, but, there are socioeconomic disparities, there's psychosocial pathways related to discrimination, there's different behavioral norms, comorbidities, and even genetic factors. So in this slide, you'll see that we find that Black people, for example, are more likely to experience the onset of a significant long-term services and support needs earlier in the life than white people. From age 51, a Black man, for example, could expect to survive 2.2 fewer total years and 3.1 fewer non-disabled years than a white man. And this has implications, not only like differences in kind of the amount of life that you have, but it also means that they might need to stop work sooner and have less opportunity to accrue retirement wealth that they could use to support paid care or maybe residence in a supportive setting. For example, over 20% of Black people experience an onset of a significant disability in their 50s and 60s compared to 11% of white people. Now I'm going to discuss care arrangements. So we look at 2 different things. One is the distribution of people that might be able to provide care. So do you have a child? Do you maybe live with another relative? And then we look at the actual caregivers, because just because you have a child doesn't necessarily mean that that child is actually going to be taking care of you if you need it. So on this slide, we see the distribution of who potentially might be able to care for an older adult with a disability. Does the person have a spouse, a child, or are they living with someone else that might be able to provide care? One of the most prevalent sources of care, an important source, are spouses or partners, because they just tend to provide more care than other types of caregivers. And that may be because as we age, a partner might not have a job and they can actually devote more time to doing it. So it's important to see who might potentially have this type of caregiver. But this just varies so much by race and gender, as you can see on this slide. Among those ages 51 and older with an LTSS need, non-Hispanic Blacks are less likely to have a spouse in their potential caregiving network. So these can definitely present disparities in the actual care received because they're related. All right, I'm going to go to the next slide. Oops. I'm sorry, I just skipped forward a slide for a second. Sorry. So this is the slide that looks at who is actually providing it to care to the person with a long-term service and support need. You can see here that white people are more likely to rely on a spouse than Black or Hispanic people. If you look at the bottom three bars of the bar chart, the red, the yellow, and the blue, these are all caregiving networks where there is a spouse involved. It is actually higher for this non-Hispanic other group, but for the most part, white people have more spousal contributors to their caregiving. Many Black people actually receive care from caregivers other than a spouse or child, and you can see that Latinos are more likely to rely on a child alone, which is this green area in the chart. On the top row is no caregivers, so that doesn't mean they don't get care, but it could mean that they're getting paid care, and that is greatest actually for non-Hispanic whites. So on this slide, we look at actually the combination of getting unpaid care, paid care, and whether you live with a family member or other person, not including a spouse or a partner. So this on this slide where it says alone, it means by yourself or with a spouse or a partner. As you can see from the figure, co-residency is a choice that is made more often by people of color. So if you kind of look at this red, the bottom part, the red, yellow, and blue, those are situations where the person is not co-residing with somebody else. You can also see that a larger percentage of people in Hispanic families rely only on a child. So even though the number of hours of unpaid care are actually fairly equal, you don't see that on this slide, but I'm just telling you they're fairly equal for all races and ethnicities. The combination of longer periods of disability and the fact that whites are more likely to pay for assistive living situations means that people of color are more likely to face adverse consequences of unmet needs for long-term services and supports. And some of those are listed in the bullet on the left of the slide. Black people and people of Hispanic origin are more likely to report adverse consequences from unmet need. So whites are the blue bar here, and you can see that they're lower at every age. And this doesn't mean that people aren't providing extensive amounts of care. It just means that not all of their needs necessarily are being met. So I just want to wrap up by acknowledging my co-authors, Melissa Favreau, who's formerly of the Urban Institute, who really ran the dynamic simulation model, and Rich Johnson, who also did health and retirement study analyses for us, and my co-authors, Bill Martin, Helen Lamont, and Lauren Anderson. If you want more information, our reports are on our website. Thank you. I need to stop sharing.
Thank you very much, Judy. One of the persons in the chat asked if you could paste the title of your presentation in the chat. They were interested.
Oh, of course. Yeah.
What the
actual
title was. Our next person is Gina Green-Harris. Gina, I know that you're looking at these same questions, but you have a slightly different perspective. And tell us what you're thinking and what your work is about.
Absolutely. Again, thank you so much for having me this morning. I will not have a slide presentation. And I just really want to do a brief overview of the work that we've been doing that is relative to actually all of what you've heard today. Our work in specific, and I'll talk about a specific area of the Alzheimer's work that we do so that folks can have a point of reference when it comes to disease and condition. But what I want to say is I think about this work when we're talking about creating these innovative programs that will help guide the work for the future around addressing the disparities, but more importantly, the opportunities to address disparities using innovative strategies that the community identifies that work for them. So really tailoring the work from research into actual programs that and then addressing the needs at the system levels. And that's the work that we've been doing here for quite some time with the work through the Wisconsin Alzheimer's Institute along with CCE. So I want to just briefly do a quick overview of our work. Thinking about our model is based on Kresman's asset-based model, along with Peggy Dilworth Anderson, one of the early investigators that talked about the need around supportive services being a tool to use to help our agers live longer and live well within community, and specifically in communities of color. And so when we thought about how we were designing our research study, specifically for WAI, was around the Wisconsin Registry for Alzheimer's Prevention, also known as the RAP study. The goal was to increase African American participation in research. What we understood is that that was one need for the institution. However, according to community, it was a tertiary need. And so what we decided was essential was to step back and think about how do we design a research study that puts community engagement first, collaboration, and then thinking about outreach, not only to community, but to healthcare providers. So we thought about this and we used this model. Our motto is meet the people where they are, but we used a model that was built solely on the voice and the quite frankly, perseverance and the effectiveness of what was the community doing right. So in working with community organizations that were already focused on Alzheimer's disease, but there was at the time no such thing as a dementia care specialist, we decided, how do we build this infrastructure with healthcare providers? And so we identified going into the homes, doing assessments with families who were recently or on the cusp of being diagnosed with dementia to talk about what's going to be those stress points, burdens, caretakers, care recipients, and then those folks who were on the journey. So we decided and developed these programs that were not our concepts, but were the concepts of the community to, one, address stigma related to Alzheimer's disease. How do we even, or what do we even call this now new disease that's developed in these Black, brown, marginalized communities? And then how do we reduce these boulders that were being presented to community and turn them into bridges as we're working with community organizations, community hospitals, and now partners with those folks who were on the journey so that we can have this bi-directional and tri-directional relationships. And so what we did is we combined our resources together and develop innovative strategies such as our in-home assessment program. We then move from there to say, what is it that we need to do upstream? So we designed and developed dementia wellness programs for those folks who we knew were high risk. And finally, we also had our original director was already developing dementia care networks and diagnostic clinics. We worked with our federally qualified health centers to develop diagnostic memory clinics, not only for data collection, but more importantly for resources for the community to have really good diagnosis, but then have one-stop shopping where we would be able to take them into resources and then also build around them care support, building respite programs within our own program so that they could then participate participate in our research studies, as a matter of fact. So those were some of the things. And then we focused next on advocacy, making sure that we included community voice. We developed a community advisory board that would help us to not only drive our programs, but to drive the research studies that we were creating through the RAP study. They gave different feedback to researchers relating to the number of vials of blood that were being taken. What other alternative strategies could we use? For example, we started using the word lumbar puncture as opposed to just saying spinal taps. Those were things that we actually utilized community to do when it came to addressing this issue that the community was finally embracing, called Alzheimer's disease. We also think about moving to the new workforce model. Why am I talking about that? Because the other piece is that we recognize that, as you saw on these slides that were presented to you earlier, there is obviously that we know there's a strong, diverse, there is these health disparities in our communities of color. However, the workforce does not match the communities that are most impacted by these diseases and illnesses. And so we talked about having culturally inclusive and culturally tailored workforce, meaning we hire from the community. We reevaluated what was needed for the sake of degrees, for the sake of making sure we were meeting the goals of our workforce needs, and what was just desired. Did everybody need a master's or PhD to do some of the data collection? Did a phlebotomist need certain criteria outside of training for phlebotomy? We did those things. And we also created these pipelines for young talent. And building from that, we started building our team. The goal for us was to create a full in-campus research study that not only recruited people, not only got the investigators what they wanted, but to build something sustainable that the community could use. And as a result of our work, we not only doubled our numbers of researchers, doubled our numbers of enrollment to now having, going from 2% to now more than 15% of diverse populations involved in our research study. We also have created multiple programs such as the Amazing Grace Chorus, such as our Dementia Wellness Program, and I can go on, but I've got 38 seconds left to talk about it. But I just wanted to bring a full scale what happens when we not only focus on the research that we're interested in, but also bringing the community along when we're doing our studies so that we can have longevity, sustainability, and future hope for really reducing health disparities. And I'll end there.
Thank you, Gina. Very interesting work. Okay, what's going to happen now is I'm going to ask a follow-up question to each of the panelists. And while I ask these questions, and then while the panelists answer them, I want to encourage our audience member to think about questions that they might have, and then put these questions in the chat. We'll get to those in about 6 or 10 minutes. So let me start out with Lauren. Thank you for your fascinating presentation. Congratulations to the big grant that you got. Can you zoom out a little bit and tell us more about general effects of the impact of social disparities on aging? So aging is not the same for everyone. How does aging differ depending on which social group you belong to?
Yeah, that's an excellent question. I think that the one really important thing for us to think about when we're thinking about aging and autistic people is that we have these lifetime disparities that autistic people experience, right? So, it's not just disparities in diagnosis of autism. We see lots of racial, ethnic, and socioeconomic and regional disparities in who gets diagnosed and when, and what services and supports are available to them. But we also see disparities in the way that autistic people are treated in society. So one of the concepts that we talk about a lot in autism is the concept of camouflaging, or the idea that as an autistic person, you need to essentially change who you are on a daily basis to be able to fit in with normal society. And our early interventions for autistic people push camouflaging and teach people how to camouflage as the primary component of the intervention. And these social disparities that are resulting from camouflaging and from social isolation and from not being able to fully be yourself within the context that you interact may be leading to things like decreased social support, increased levels of stress, lack of ability to access healthcare services because of the way that folks are discriminated against within healthcare settings and the way that healthcare settings are inaccessible to people. So it really tells us a lot about how a lifelong lived experience of social isolation and social exclusion, and being told by your service providers that you need to force yourself to fit in and force yourself to be different in order to fit in, may lead to these long-term consequences. And, in our advisory boards and in our qualitative work, this is the primary thing that autistic adults are talking about is, how does all of this stress and all of these mental health symptoms that I'm experiencing from living in this world that's just not, it's not accessible to me. How does that impact my aging, and why is this happening to me, and why isn't society more accepting and more accommodating?
Thank you, Lauren. Before moving on to Gina, I want to point out, if you write questions in the chat and they're directed to a specific member of the panel, could you please put the person's name together with your questions? No, actually, Judy, I want to ask you. So you bring a lot of experience to the table. You've done the work for 10 years. You've been for a decade at the Department of Health and Human Services. Can you tell us about any shifts that you have observed in the last 10 or 15 years? What did people think 10 years ago? How did they approach certain problems 10 years ago? And how has that thinking changed over the years?
That's a great question. And I'm not sure I have a full answer, but I think one of the things that we just, can't avoid mentioning that's really changed in terms of our understanding is what's happened since COVID is one thing. And I also sort of feel like one of the things that Lauren mentioned, and I think is really true, is just that disability rights activism and actually Gina mentioned too, this sort of role of stigma in our understanding of policy issues. I think both of those things have really come to the forefront for me. And one of the things that we really have been working on a lot, and I think was really highlighted by the pandemic, are the availability of home and community-based services and how much they're impacted by the workforce. This workforce that works both in the community and in nursing homes. They're so important, and if they're not there, these services really can't be provided. I think another thing that came out of the pandemic was kind of recognizing the huge role that family caregivers can play in delivering those services, because there were a lot of exceptions to rules in states that hadn't been did start allowing some families to actually provide these services when there wasn't the availability of home and community-based workers. So that's kind of a solution that's come out there, and I think people are thinking about that differently. I think just in terms of destigmatizing and activism, I think there's just been an increased focus, at least in my space, about how we measure disability in the federal government. The census recently tried to change the 6 questions that they ask in the American Community Survey, and I think for the first time there was a lot of outcry. There were a lot of stakeholders who felt that they hadn't been included and that they should have been included. I think there's been an increased, understanding that maybe disability is like an identity and not just this stigmatizing thing. And that I guess the final thing is that I think the pandemic really opened up employment opportunities, and you saw a big shift in people with disabilities engaged in employment. And I think that people are kind of understanding that maybe some of the obstacles that were there shouldn't have been there. And then finally, I think we are seeing sort of a lot of more older adults, and it's caused us to have kind of more focused conversations, not just on retirement, but how do we include older adults better in the workplace. So I guess that's all over the place, but that's my answer.
Great. Thank you, Judy. Gina, you're based in Milwaukee, and what's so special about you is that you have worked very closely with a large number of communities, organizations, and groups in Milwaukee. So we have people here from all over the country, of people from Minnesota, New York, Oklahoma, Texas, California, and we've one person from London, Ontario. What advice can you give these people? Many of these people are practitioners or interested in trying to do something about growing needs around aging and disability. What practical advice could you give them?
Yeah, that's a great question. You know, as I was listening to the other presenters, thinking about what is unique, what is different, I think what I would recommend and think about, and what we've done, is we've made it our business to really think about how do we, as providers, as practitioners, whatever we want to call ourselves, community-based organizations, what can we do to strategically develop our intra-network together, to do these more connected resource and combining resources across the spectrum so that we can reduce the burden on our aging and our agers and community, and those who specifically have these disabilities and difficulties and challenges. How do we make life easier for them? And what do I mean by that? What I mean is that we've got to come up with innovative strategies. So the UW-Madison, our program cannot do this singularly. So we have to work with our aging disability resource centers. We've got to work with our community-based organizations. We've got to work with public policy makers. We've got to come together to create these networks that understand the difficulties and the challenges, but also we can then discuss what are your challenges, what are your barriers, and then we can come up with common solutions that we believe that will be able to, and bringing, by the way, community to these discussions with us to say, how do we design something that is not for us, and it may not be as convenient for us, but it does build on the convenience of the community. And I'll give another, I'd love to give this example, because when we talk about diverse communities, and Judy did an awesome job of talking about the caregiver needs based on race and ethnicity and gender. But here's the question I ask that we often forget. Those people who are developing and aging and even living with disabilities, most often, at least in these under-resourced communities, are also still parenting or grandparenting and caring for younger folks. So we don't even talk about this intergenerational issue that we need to be talking about, of how to support these folks who are aging on the other end of the spectrum that cannot quit their jobs but are not functioning well in them, but they're taking care of their grandchildren, great-grandchildren, or cousins, or whomever, but they definitely need the support of our systems to do that. We, as those who are providers, in whatever context you take that, need to come together, in my opinion, to start working these situations out collectively.
Great, thank you. I see one question in the chat that has to do with the dementia program, and the question is whether that exists also in other states. Gina, can you say something about that?
I can. So in Wisconsin, we have the Dementia Care Network. Dementia care programs actually are federally funded and federally mandated, and they have programs across the country that are now working with folks in dementia care. Everybody's capacity is different, so I can only talk about what happens in Wisconsin. But yes, there are dementia programs. I can tell you that our model that we're using has been discussed at length across the country, and I do know that there are others who are using a very similar model as well. So they are there. I would encourage you to think about checking your Alzheimer's Association out if you're worried for dementia, thinking about the Aging Disability Research Centers, resource centers, and then also your Alzheimer's Disease Research Centers as well. There's so many caveats that are actually doing dementia research that is inclusive of programs such as what I'm talking about as well. So definitely check out some of those resources.
Thank you, Gina. Extremely helpful. Carrie Wong posted a link in the chat to the health and retirement study. It's a large-scale study, I think 20,000 Americans conducted at the University of Michigan. I just checked out the website. I thought it looked incredibly interesting. I don't know, I don't want to put you on the spot here, Lauren or Judy, but does one of you have anything to say about that? Have you heard about that study, or are you aware of it, or do you know anything about it?
My slides are based in large part on it. So yes, it's a great resource. I wish we actually had it going back for younger people, because we, like the rich kind of sources of information about who's actually, helping you out, and how much time does that take? And do you need Medicaid? All of those, are your needs being met? We don't have a source of information like that for younger people. So yes, it's an amazing resource.
Wonderful. Thank you. Then I may have one question for Lauren, and I don't know if this makes sense. So you're a researcher, you do research on this topic, and my guess is that at least some people in our audience have a little hard time imagining what it means to research, to be an academic researcher who works on these topics. Could you sort of explain to somebody who is not affiliated with a university how you spend your day and what type of research you do and how you go about acquiring knowledge and contributing to this topic?
Yeah, so I went into research. I was a practicing social worker working with autistic people in the community. I've worked with people on the autism spectrum since I was 15 years old. So for the vast majority of my life. And I went into research because as a clinician, there were questions that there just was no research on. And I wanted to be able to find out answers to questions that were important to the people that I was working with and were important to agency leaders and to policymakers who were, making the big decisions about how we provide services and supports to people with disabilities across the lifespan. And the way that I sort of spend my time is, I have a lab where, we have office space, and all that having a lab means is that you have office space in a building where people who work with you can, have computers, and where you can bring people from the community in for either data collection or to talk to you and help inform the type of work that you're doing. And I'm a very collaborative researcher, so I have collaborators across the country and across the world. And I spend a lot of time on Zoom with my collaborators. I spend a lot of time writing scientific papers, but also writing outreach materials. And then I spend a lot of time analyzing data and collecting data. So we bring people in. So for our longitudinal study, as an example, we're bringing people in for essentially full day assessments and doing a very large interdisciplinary assessment on them, and then using those data to put into a pooled data set to be able to understand patterns within our sample of folks who have participated in the research.
Hey, thank you. I thought that was interesting. Gina, there's one question for you. One of the members in the chat said, hey, it's a great idea, that resource hub for the community. And the question is, how do you go about putting that into action? And do you have something you want to say about that?
Yeah, so I think the ideal and notion of research hub is definitely growing across the country. I know it's growing in Wisconsin. I think what we definitely have to do is think about how do we identify strategies to not only develop a research hubs, but funding to continue for them to be sustainable. I would consider our office, for example, is a office that is based in Milwaukee. It is a university program. It is sustained through university funds as well as other dollars through NIH and grant funding. And so we totally meet the criteria to think about us as a research hub. One of the challenges that we do face, and I think other research hubs may face, is being recognized from campus about the work that's being done, how to sustain this work, because it does go beyond those traditional research walls, research ideologies and thoughts, and it's like, oh, you're a community partner. No, we're a research hub that's bringing what's on that campus into community and then taking it back so that it can continue this kind of reciprocity, kind of reciprocal, I should say, work. So I think that I propose that we as our academic institutions continue to grow and have strong desire to do community-based research, that we look at how do we create these new funding strategies that would be able to support research hubs in a very healthy way, that we would not just start them and then after 2 years or 3 years of the funding's gone, we've not identified ways to have these networks hubs continue on. And I think a lot of that will have to do with how we build it and who's included in that process, which it cannot only be academically owned.
Wonderful. Time's nearly up. I'm going to ask now each of the speakers to tell us what their 20 or 30-second take-home message is for our audience. Each of you, if you want our audience to remember one thing from today's webinar, what would that be? Lauren.
I think I will say that our big takeaway is that people with autism get older and they age, and we need to be doing something as a research and provider community to help them age well in the way that they would like to age.
Judy.
I guess that I would say that sometimes, like, especially when you're younger, you don't think about it, but that most of us actually are going to need some help as we get older. And I would like us all to think about just kind of creative ways we can do that. I love these programs like that have like a younger person get a room in exchange for some help and things like that. But just that we need to be creative and supportive.
Gina?
Yeah, so my takeaway would be that recognizing that research is inclusive of human and people, and that without an inclusivity concept and making sure that we are not just doing research for the sake of investigators getting content and knowledge, but research really is designed to improve health conditions and outcomes for our communities. And I think that's really what we try to do and keep that message out there.
Thank you. I'm incredibly grateful to the three of you. You are incredibly qualified, charismatic speakers who do fascinating works, and I'm very grateful to you. The comments in the chat reflect a similar positive impression and excitement about you. Thank you so much. So this was a webinar by the Institute for Diversity Science at the University of Wisconsin-Madison. Our mission, one more time, is to promote a data-driven, evidence-based work related to diversity, equity, and inclusion. If you know anybody who wants to support this work financially, organizations, private philanthropists, etc., please point them to our website. The website is ids.wisc.edu. And I also want to encourage you, the audience member, to explore our website and look at all the exciting work that our affiliate faculty are doing. Lauren Bishop is one of them. There are many others who do fascinating work on a variety of topics related to business practices, to health inequities, to policing, the judicial system, etc., educational disparities, etc. These are all people who work on how can we make this world a better place? How can we reduce disparities? And how can we create a better future for tomorrow for everyone? Thank you very much. Have a wonderful day and goodbye.